Hi everybody and welcome to Decoding Digital Dentistry. My name is James Taylor and today I'm going to be talking about decoding digital diagnosis using CBCT in aligner and implant treatment planning. Now that does sound quite boring, I get that, but actually it's really innovative and it's actually quite exciting. So hang fire, listen to what I've got to tell you hopefully and you'll find this enjoyable. So I'm a clinician, I'm a GDP, I do implants, I do restorative dentistry, cosmetic and aesthetic dentistry, orthodontics, and I've got certificates in those fields. And so my general practice revolves around all those disciplines merging together. I'm concentrating at the moment more on orthodontics, doing fixed and removable orthodontics. I live in Leeds, North Leeds. I have a practice which we started 2 years ago called The Dentist, and we embrace digital technology in the whole. We've gone for the latest and the best we can, and for that reason we're using a lot of Dentsply Sirona's products, and we're finding that they are allowing us to advance and move and provide our patients with the best we can in dental care. So that involves a number of things. It involves the radiography we're doing. We're using digital radiography, we've been using CEREC, milling, and also scanning teeth for aligners, etc., for many years as well. We incorporate their software such as CEREC Ortho, and we use that for our SureSmile cases. And we're also integrating all that software into our treatment planning and execution, both in terms of aligner treatments and in terms of implant care for our patients as well, and restoratively with respect to CEREC, Celtra, etc., milling, crowns, veneers, and inlays. In particular, what I'm going to talk about today is how we integrate the digital workflow into SureSmile and how we do our aligner care and treatments. So we have seamless digital integration, as you can see. We're using both the CEREC scanner, the PrimeScan scanner, sorry, and then we're also using the Orthophos SL to get the digital diagnostic imagery we need, both in terms of dental scanning and CBCT scanning, to allow us to plan our treatments and execute them in the best way possible for the patients. We also have a laboratory called Vivid, and again we're milling blocks, as you can see from the picture shown here, and we're milling and also using implant guides, and we're also Atlantis certified, and so we've got the whole workflow from actually the diagnosis, the planning, the treatment, and to the laboratory work, all using the Dentsply Sirona digital pathway, and for us it's working beautifully well, and we're enjoying using it. Patients are getting the benefit as well. So let's look at the beginning. Almost every treatment begins with a reliable diagnosis. That's key. And it should be precise, quick, and the image should be easy to capture. And with that specifically, we're talking about radiography. Radiography is key in many, many aspects of dentistry, for the diagnosis and for us for the planning and execution of that treatment as well. Whether it's a simple filling or whether it's something more complicated such as root canal therapy, implant planning and treatment, or in the case which I'm going to demonstrate today, aligner treatment as well. More importantly, a high-quality X-ray with maximum clinical information allows me to feel comfortable and confident, but also gives the patient the confidence as well. It gives me a clear view of the case, and I have everything needed for a successful treatment. Now, again, it's not just me that benefits from that. I get peace of mind, I get control, I get the patients can get involved in the whole planning and process and see exactly what we're trying to achieve and how we're achieving that. So we use the Orthophos SL. This is our machine, the picture that you see here. That's the machine in our surgery. But the Orthophos SL is a 2D and 3D CBCT machine, generating 2D OPT and 3D 3D CBCT images. We also have a KEF arm now as well, and we're taking our own KES with this machine. There's now the new Axios, but essentially they're very similar machines. The key to this machine is not just the pictures it takes, but how it takes them and the dose of radiation it's providing to the patient. And that's really opened up an opportunity for us to enhance the way we plan and execute our treatments. We have three options with respect to the field of view and how large a field we're taking with respect to the image we're capturing from the patient. We can do a 5 by 5.5, we can do 8 by 8, or we can do 11 by 10. We're normally just doing an 8 by 8. It allows us to catch the upper and lower jaw, allowing for planning for implants, allowing planning for aligner treatment, which I'll go into more detail with. But we'll also use the 5 by 5.5 when we're doing root canal therapy, when we only need a sectional small view. The beauty of this machine and the beauty of how we're utilising this machine is that we're using a low-dose CBCT. Now that's unusual to a normal standard definition or high definition CBCT in that the effective dose to the patient is less millisieverts to the patient, and in fact we're using the same effective dose that we would do for a 2D X-ray. So I can take a 3D CBCT with the same effective dose to the patient as a 2D OPT. And that's changed everything for me. It's been a game changer. That's meant we can now incorporate 3D X-ray scanning into my planning for a line of treatment without having to expose the patients to to a higher dose of radiation, which maybe I won't be so comfortable with. I don't need to go into too much detail. You can see yourself the special filters, etc., that the machine has, which allows this low dose mode. But essentially, it gives me a very enhanced image in 3D using just a 2D effective dose to the patient. You know, you go on an 8-hour flight to the States, and you're between 32 and 75 millisieverts. A 2D image, which the low-dose CBCT is within the same, region of dose as a 2D image. So we're using this 3D low-dose X-ray all the time, where we can. So let's talk about some patients that have benefited from this. So this is Adam. Adam's a dental student at Bristol, came to see me, and he had a few problems. He's got a class 1 malocclusion, narrow arches, the teeth are fairly retroclined, tooth height widths weren't quite right, and he wasn't happy with the amount of support he had on his lips, just didn't like his smile, wanted to improve it. His grandfather's a dentist, said, your teeth are lovely, they're fine, leave them alone. But he wanted more, and so we looked at a way in which we could treat Adam and improve what he saw and what he felt and enhance his smile. And this is the final result. Our objectives were to maintain the class 1 occlusion, we wanted to procline the labial and buccal segments, and we wanted to create space for composite bonding to improve the tooth height width proportions. Essentially, we just tipped out those teeth, created space, and provided the smile, which he has now, which he's very happy with. He's in his 4th year as a dental student, and he's enjoyed the experience, and it's been a very digital experience, a very cloud-based experience as well, because we did a lot of the consultation online. So it's been a real digital workflow for Adam from start to finish. Now, when I talked to Adam and we talked about treatment, I didn't want to do this blind. And it's very key and important for the way I treat patients that I've got control of the way I want to treat them. I want to know exactly what I'm doing, the effect my treatment is having, and what I'm going to end up with at the end. So flying blind, essentially, or working blind, as this guy obviously is, doesn't work for me anymore. So we use low-dose CBCT, as I mentioned before, and it's changed everything. Now, this is a low-dose CBCT. You can see the 3D rendition over here, and you can also see the sectionals down the side. The quality is as good as, I guess, a CBC, a regular definition was a few years ago. And what we can now do is we can mesh both the dental scan with the CBCT. And that gives me layers that I can then remove. So blue with SureSmile, and this is the SureSmile platform that you can see here. Blue is before, that's the pre-treatment scan. And you can see on the top scan, you can see you've got the blue teeth, you've got the gum overlaying from the dental scan, but on the lower visual, you can see the gum has been removed. And I can see a number of things that I couldn't see before with just a regular dental scan. I can see where the roots are within the bone. I can see how much root coverage the bone has given. So I've got a root bone level image, which I can then use to help me plan my treatments. So this is the predicted outcome for Adam. Once I've gone through the planning process, the prescription, it comes back from SureSmile, and this is what I look at after my final planning, ready to go to aligners. Now, it doesn't look finished because it isn't. We'd planned this in order to do some composite bonding, so I created spacing between the teeth. But more importantly for me, I can see where the teeth are and where the roots are in relation to the bone. And that is key. That is key to the safety of the treatment and to the ongoing health of his dentition and supporting structures moving forwards. And here you have the before and after, the before currently and the predicted after again. And you can compare where we are. The blue is before and the white is after, as you can see. And what you can see is that the teeth are where I want them to be, but also the root positions are enhanced as well. They're enhanced in terms of the torque of the root, the position of the root within the bone. You can see in the upper right lateral incisor how we've actually increased the torque, but not only have we tipped the crown of the tooth, we've also tipped the root back into the bone as well. So we've got more bone coverage over that root. And I can do this on every tooth around the arch. Look at the lower right 6, look at it before, and look at it afterwards. So I'm moving those teeth not only for the correct occlusion aesthetics, but now also to enhance the amount of bone that's around the teeth. And the low-dose CBCT allows me to do that. And SureSmile, the software, allows me to do that. So I'm utilizing this with all my cases, unless I've got a really good reason not to, and as yet I haven't found one. So again, this is Adam before, the blues before, that's his dentition before, and at the side here, you can see where the predictors is with the gum taken away, so we can see the bone and the root. And that's the after, that's the post-op, after we've done the SureSmile aligners, and you can see we've created the amount of space we predicted, and the teeth are as we anticipated they would be, and therefore we should be able to presume that the roots are where we want them as well, because it's all been planned in sync together. So I'm very comfortable with that. I then proceeded to the bonding and the whitening, and then to the final result. Where else do I use CBCT, and where is it critical for me? Well, comprehensive, multidisciplinary treatment planning. As I said, I do, in my practice, we're doing orthodontics, we're doing restorative care, we're doing implants. Now I do all those disciplines, but my colleague and I work together, and sometimes he'll do the surgery rather than myself for implants, and I'll concentrate on orthodontics. But working as a team, and we're planning everything and processing through that for the patient's best possible care and well-being. This is Ross. Ross had a number of issues, but he ended up having SureSmile, implant, and bonding. And it was a combination of treatment where the CBCT, again, was critical. So he had a bit of a problem list, and we'll go through it. Missing the upper right 2. The upper right 3 was transposed and in the wrong position, as you can see. It's moved mesially there. The aesthetics were poor. He had a retained upper right C, so the retained C, the lateral's missing, and the 3's plopped in the place of the 3. Deep overbite, median diastema, and missing lower right 6. And he wanted to improve the overall aesthetics. He knew that upper right C was about to be lost. It was loose. There was nothing really left of that, and he was going to lose it very soon. So how do we improve both the aesthetics of the teeth and replace that missing tooth? Again, just from other angles, you can see the issues he had. And so our objectives. The objectives list, really important. We have objectives. We know exactly where we're going, the direction of travel. So we want to close all anterior spacing. We want to improve the colour of the teeth. We want to improve the aesthetics of the upper right 2, which is the upper right 3 that's been transposed into the upper right 2. So we want to make that upper right 3 look like an upper right 2. We need a long-term replacement of that upper right C, which will become the upper right 3. And we want to reduce the overbite. The space on the lower right, he was happy to leave for now. So it was essentially the upper segments he wanted to improve, and so we addressed that for him. So the plan. We're going to align the upper and lower teeth. We're going to create space for bonding, so we're going to redistribute that space. We're going to improve the position of the upper right 2, which is actually the upper right 3. Now, why are we doing that? Well, we're doing that because the upper right 3 is a very curved tooth, very bulbous, and so the aesthetics of an upper right 3 are very different to the flat lateral that he has on the upper left 2. So therefore, we're going to use orthodontics to improve the position before we do some bonding to reshape that tooth. We're going to do tooth whitening. Then we're going to do the bonding to the anterior teeth. We're then going to remove the upper right C and put an implant in the upper right 3, and then we'll just give him long-term retention. And long-term, we'll replace that. We'll do the implant, replace that tooth, but that's when he's ready. So the success of this treatment is based on a number of things. We need to get correct spacing between the anterior teeth for bonding. We need to make sure that we've got enough space between each tooth so that the tooth height, width proportions are correct throughout the whole labial segment. We also want to correct the alignment and torque, essentially the root position of the upper right 3. We need that root tipped in. We need to remove the bulbosity over the gingiva here, over the buccal area, and make that tooth flat as flat as we can, so it looks like it should have always been there, and it was essentially an upper right 2, an upper left 2. So we're going to get the symmetry as close as we can. And again, I don't want to shoot in the dark. I don't want to just guess. I don't want guesswork. I like control. I want to be able to plan this with the reassurance that what I'm doing is going to give me the results I want in the safest possible way for the patient. It makes my life easier. It'll make your lives easier as well. So we want to keep it simple. We want to be in control. We want to plan it using all the tools we have available to us. And again, what did I do? We scanned the teeth using the prime scan, and then we took a low-dose CBCT. We meshed them together with the photography, and then we moved forward to the planning. So again, the blue is before. This video will show you part of the planning process. So blue to white, you can see the gross movements of the teeth. In a minute, you'll see the animation as in a slower movement of the teeth. But you'll see that essentially, we're trying to create the space between the teeth to redistribute, so between the lateral and the central. We've got sufficient space now. We've closed that median diastema, and we've got sufficient space to actually do our bonding. And you can see how we're actually moving those teeth, the upper right one, upper right three, into the alignment of the arch, but also we're looking at the root positions of those teeth. And this is the beauty of the CBCT being incorporated into the actual plan. I'm not just looking at teeth alone. I'm looking at the teeth, I'm looking at the dentition, but I'm looking at what's going on underneath. I can see the roots moving. I can anticipate where I'm going, and I can move forwards in a confident and predictable way. So again, we'll look at before and afters here. So here, on the my left and right. On my left-hand side, you can see the before picture, and on the right, you can see the after picture. So we've closed the diastema, we've reduced the overbite, and we've aligned the teeth. We've also improved the position of that upper right 3, which is actually the upper right 2. And I'll demonstrate that a bit more from other angles in a second. But there, we've done some initial bonding as well after that, just to give us an idea of where we're going. It's not finished yet. It's just some edge bonding just to show where we're going. So we've got an idea of levels, of occlusal plane, etc. So we can move forwards then with the implant, and then we can finish everything off at the end. But the most important part for me and part of the planning was with that upper right C, which is upper right 3, which replaced the upper right 2. And you can see from the before and after photograph that the bulbosity of that root is much less. And I've pushed that root, I've torqued that root into the palate. We've made it less bulbous on the buccal surface. It's reduced the glare, you can see from the photography, but it's meant that then I can restore that tooth in a way which will be more adapt to looking like an upper lateral incisor. Again, you can see here, the top visual is before, the blue, the low one in white is after, and again, you can see how much root has been moved inwards, how much bone is now covering the post-operative rather than the pre-operative. So we've got improved root position to remove the buccal root prominence of the canine. It allows improved aesthetics to correct the upper right 3 to look like an upper right 2. And it's a digital meshing of the scan in CBCT that's allowed us to do this predictably. And I'm doing that all the time now. We're predicting the movements, we're seeing where the roots are going, and we're using that to enhance our care for the patient. And so without this, I'd be guessing. I'd be guessing where the root was. I'd be looking at the crown and presuming that I'm actually torquing the root in. But am I really? I can now show that I am. Again, before and after we've done the bonding. And again, the bonding's not finished, it's just initial plan, and he's not finished treatment yet. He's actually now had the implant placed, and once the implant's is integrated, we'll then move forwards and we'll finish off all that restorative care at the front. We'll finalise the bonding, get the aesthetics correct. I'll go back to that second. We'll finish everything off once the implant's integrated, like I said, and we'll reshape that tooth further. But already, that lateral, which was the canine, is already looking more like a lateral than the canine. And you can't really see the bulbosity of the root over the gum there at all. It's really been tucked back in. So I'm happy with that, and like I said, using the CBCT, it's giving me the control to be able to do that in a predictable way. So another patient, asymmetry of the upper arch. If you look at her smile, you'll see how the smile breaks on the right-hand side there. The smile on the left is lovely and essentially as we'd want it, but on the right, it breaks because she hasn't got the support buccally due to the narrow asymmetric arch on the right-hand side. So how do we treat this? Again, I could just expand the arch very easily. I could roll the dice, say, right, roll the dice, you need arch expansion. Let's just go ahead with it. Let's see where we go. But I don't want to do that anymore. I don't want to just guess. I want to do it in a predictable way that's controlled, that I can see what's happening. So we took a CBCT, a low-dose CBCT. Look at the quality. You can see the 3D rendition I'm getting of that. It's brilliant. I can see everything I need to see. I can see the teeth, I can see the roots, I can see the prominence of the roots, and down the side I've got all the sectional views as well. So I can see everything I need to see with regards to the root position, the crown position, and how that relates to the bone as well. Again, the blues before. This is a video showing how we actually look at the plan in the SureSmile software. We can take the gum away again. And then we look at the before and after. The blue is before, the white is after. But I know now by expanding that buccal segment on the right-hand side, I'm not breaching, I'm not causing the roots to go too far buccally and come out of the bone. I'm not going to cause any problems in health as far as recession, etc. I'm not going to cause any problems at all. If we go back and watch it again, you'll see also that other teeth, I'm taking this opportunity to enhance the position of other teeth within the bone as well. The upper right three, the centrals, upper and lower. You'll see that they're now in a much better position in the bone, and I feel a healthier place as well. So I'm using the CBCT along with the dental scan to plan my ortho treatment, but plan in a way that I'm getting a number of wins. I'm winning on the aesthetics, I'm winning on the actual treatment plan, in that I can control the tooth movements, I know where the roots are and where they're going, and therefore my mechanics can be better as well. I can do simpler movements. I can see where I can avoid issues with roots clashing, all sorts of issues I can avoid. But particularly on this case, I can see where the expansion is, I can see where the bone is, and I know I'm doing no harm. And this is before and after. Now again, we're just in the refinement stage with this patient, but look at the arch shape. So I've achieved my goal. I've got a beautifully symmetrical arch there. I've given it arch width. We've aligned everything. There's a minimal IPR taking place, but as a final result, with regards to the symmetry, I'm very happy with that. More importantly, when you look at her smile now, you can see, look at the lips. Look at the lips. Look at her right lip and the finished, or the almost finished case. Look how we've removed that break that she had. So she's now got a beautifully symmetrical smile. The lips are formed nicely both sides, and that's basically been down to the support, from the buccal support from her premolar and molar segments. So we've corrected that arch, and aesthetically, facially, it's improved her smile. But it's been done in a controlled way. And for me, that's key. So this case, this is the sleepless night case. This is the incidental finding case. So this gentleman came to see me. I want to straighten my teeth. Well, as you can see, he's quite a complicated bite. He's got a class 2 div 2 malocclusion, a really deep overbite, traumatic, I think, palatally as well. Not the kind of case you'd be like, yeah, easy, we'll sort this out for you. But I said, look, let's have a look. Let's see what the options are. Let's move forwards on that basis. He understood there'd be compromises. He understood there'd be a lot of discussions had, but we moved forwards with a diagnosis, and then we could move forwards with a treatment plan. So he came to see me for the full assessment. Great. And we took the scan, we took the low-dose CBCT, we took the dental scan. And again, you can see the teeth here. They just reproduce what you've already seen in the photography. And this is it from the occlusal views, from the upper and lowers, and from a bit of an angle view. And yeah, you know, we can correct the alignment of the teeth. The occlusion is going to be hard as far as the AP, whether it remains a class 2, which he will do unless he has surgery. But we can camouflage this. We can do treatments to improve this. We can use some IPR. We don't have to procline that upper labial segment. We can keep it fairly retroclined, and we can give him a nice result, which will be compromised, but we can give him a result that he would be happy with. We took a low-dose CBCT. That was the APT we took, which comes from the CBCT. That's the sectional view of the APT. And again, you can see how he's got some impacted wisdom teeth, lowers on the upper right side. Other than that, nothing of any real consequence on the X-ray that would set the alarm bells going. The filling on the lower right 6 may need some attention, but that's not going to affect my care and treatment for him. However, I don't want to go to jail, and I don't want any problems, and I want an easy life, and I want to do things in a controlled way. Let's show you what happened with this guy. So we got the information back from SureSmile. I started looking at the plan, the proposal, or before and afters, etc. This is the before still. And I'm looking at the overall plan and saying, okay, so the teeth, I'm going to start moving the teeth. I think this may have been actually a DIY case, which is why it's a therapeutic model, a diagnostic model rather. I want to see what my options were. So that's why the plan's not being given. But as I'm looking at this model, I'm looking at the lower mandible, and I'm thinking, there's something wrong with the lower scan. There's a bit of a defect there, just in the labial segment, just below those lower incisors. And I'm looking, I'm thinking, I'm about to get on the phone to SureSmile, say there's something wrong with the calibration or the imagery, etc. There's a big hole in my jaw. Anyway, I had a look at the CBCT in more detail at that point, as I would do normally, and this is what we found. A lovely big cyst in the lower anterior mandible area, which I would never have known was there. There was no symptoms, there's no evidence of that, there's no swelling, the patient had no symptoms at all, no idea. But only because I took the CBCT, the low dose CBCT, to help my planning, did I know that. And again, if we look at the 3D rendition, which I immediately went to, you'll see exactly what is there. And there's a huge crater in the mandible. And it was a shock to him. It was definitely a shock to me. But I'm just grateful, thank my lucky stars, that I'd actually done this before I actually stuck anything with any orthodontic force on those teeth, because we all know what would have happened if that would have been the case. As a worst case, it'd have had a swelling. As a really worst case, those teeth would have fallen out. So that was a real shock to me. I again thank my lucky stars. I've done the CBCT, the low dose CBCT, but the diagnostic yield I've had from that is massive. Not only have I been able to check the teeth, check the position of the roots, plan properly, but I've diagnosed this issue, which is a big issue, especially if you're trying to do orthodontic movements on teeth with a huge cyst with no other presenting complaints or evidence of any issues. So we explained the problem. It was the lower left one, the lower left two, which were non-vital. And when we asked him further, he'd actually had trauma to those about 25 years ago that obviously died. He had no idea and formed this huge cyst, this ridiculous cyst, which had caused all that problem. Anyway, day 1 and day 90, we took an X-ray, and you can see we're already getting bony infill. So that was great. So we knew that we were in the right direction. More importantly, I took another low-dose CBCT 6 months later, because now we are going to look at doing some orthodontics for him, because now we're in a position where, as you can see from the scan, and this is on a low-dose setting, again, it's the same low-dose CBCT, and look at the detail. I can see exactly what's going on there. The cyst is healing, there's bony infill happening, and so I'm very confident that things are improving. And again, from another angle, you can see again that the cyst is resolving. It's healing beautifully. So I'm very happy with that. And again, more importantly for me, I'm using low-dose X-rays, but getting amazing clarity and detail for diagnostic purposes as well. And that scan I'll now use, go back to SureSmile and start preparing my plan when I rescan his teeth, and we mesh that together and go through a whole planning process with him. So what, when, where, and how? So this is Lauren. Lauren came to see me saying, I'd like to improve my smile. My teeth are a bit crowded. My friends have had some orthodontics with you or some aligners. I'd like it too. I'm like, great, okay. And I look at Lauren from a distance and I look close up and it's like, oh, okay. And you can all see what's going on there. She's mid-30s, but that's a lot of recession for someone in the mid-30s. And she actually wasn't aware of the recession. She had no idea it was even there, didn't know it was an issue, didn't know it existed, just knew her teeth weren't straight and wanted to improve them. Again, a bigger photograph shows you the extent of the recession and the issues that she has moving forward. So how do we treat this? What she wants orthodontics. Well, are you happy to put orthodontics on there, to do orthodontic treatment? How do we, you put an arch wire on there and you're going to get expansion. Well, expansion for her would be awful because you're going to move those teeth out of the bone. The recession is going to get worse. We're going to increase the torque on those teeth because they will. She'll get expansion because she's quite narrow, and that will be detrimental. So anything I do for her has to be planned. It has to be planned in detail. Now, I spoke to periodontists about her treatment. Nobody wanted to touch her. The phenotype of her gingiva was too thin, and essentially it would be unstable. So coronal advancement of the gum is really not satisfactory for her. So I had to come up with a way of actually planning to improve this for her, but also in a way which actually provided a healthier outcome for her as well moving forwards. So we looked through our different options. Sorry, I've gone the wrong way. We took a scan, a low-dose CBCT again, and guess what? There was a root filling on the lower right 5. I can see it on the scan. In a bit more detail, I can also see there's a problem there. Lauren, have you had any problems? Oh, I occasionally get a swelling on a tooth down here. Okay, great. We look at the scan section, and again, this is a low dose, and I can see in detail that she's got 1 canal filled on what looks like a 2-canaled tooth. And again, this is in the low dose mode. So what do we do? First of all, we re-root fill the tooth. So I re-root filled it. I've got a nice root filling. I've got the angle. We're right down to the apex. So that gives a good start to moving forwards. I then took a scan 6 months later, let everything heal, and now we can see how that is resolving. You can see I've got both canals now, and also you can see that lesion is now resolving with bony infill. And again, low-dose CBCT. These are the same CBCT, it's the same millisievert dose as we'd use for a regular OPT, but my diagnostic yield is huge compared. So the patient benefits are massive. Pre-op, 6 months later. Okay, sorry, pre-op 6 months later. You can see exactly how we've improved. The cyst is healed, basically. It's almost fully healed, bony infill, and we've got both canals. So that tooth's sound. We cannot worry about that anymore. But I know that in the confidence that I've got the diagnostic evidence for that as well. So we presented Lauren with a plan, lots of options. Periodontal treatment to do the coronal advancement. We could use composite bonding. We could use veneers. We could shorten the teeth. All sorts of options. We had to go through a comprehensive planning process to be sure that Lauren was fully aware of all the risks and all the benefits and all the options available for her treatment. So we prepared this. I think there were another 4 or 5 pages talking about all the options available to her. In the end, we decided we'd move forwards with Sure-Smile aligners because I could plan exactly what I was doing to those teeth. And I could give her a benefit, both aesthetically, and also I could actually move those roots into a better position within the bone, but do that again predictably in a way in which I was in full control of. Look at the blue before and the after as are predicted. And look at where the roots are. Look at the position of the teeth. I'm trying to move those roots back into the bone. You can also remove the bone. So I remove the gum, I can see the bone and the teeth, but I can also remove the bone and just see the teeth and the roots. So I can actually watch the roots move and I can see where they're going and I can see evidence there that, look at the upper left 2. We're talking the root in. Look at the upper right 2. We're moving that better position, but we're not pushing the root out. We're keeping the root in the best position possible for that. So I've got total control of not only the crown position, but also the root position. And that's purely by virtue of this CBCT I'm taking and meshing those together. After the first set of aligners, that's the blue. She's now in refinement. The white are the proposed after the refinement. And all I'm trying to do is enhance the position of where I am. Enhance it further, basically. So before and after. So that's where we are now currently, before and after. After is at the refinement stage. We've just finished refinement. And we're now planning on the next stage moving forwards. Again, before and after. So I'll go back. So before and after the refinement, yes. And if you look at the upper left 2, the 22 tooth, look at the position of the root. Look at what we've managed to do there. We've derotated the root slightly, and we've also pushed the root in a palatal direction. So look at the coverage of the gum around the root on the slide on the right. You'll see there's much more coverage of gum around that root. So we're helping her. We've given her a better outcome than she started with. The gum is in a better position around the root. So she's in a healthier position, a healthier place. We took 2 CBCTs, one at the beginning, one before refinement. And this for me is key. From those 2 CBCTs, I could look particularly, that's the upper left 2, the one I showed you before. Look at the position of the root. not only the crown but the root as well. The root has been tipped in palatally. We've got more bone coverage on that root. The apical third has moved inwards. So I'm very happy with that. And I can see it clinically in where the gum is in relation to the root as well. We've derotated it and we've tipped it. We can also look at the crown position and the torque, and you can see how we've moved the root in. We've not just tipped the crown out, we've moved it in. Okay? So for me, you know, I feel the patient, she's won aesthetically, and she's also winning as far as health as well. And here we are currently, again, this is where we are at the moment, before and after a line of treatment. And I don't think there's anywhere else I can now go with this as far as orthodontics is concerned. So it's now going to be a restorative plan moving forwards, and we're probably going to do some bonding in some description, whether with some gingival coloured composite, and then some white composite as well combined. We don't want to make the teeth too long. We're just trying to work our way out how we're going to do some minimally invasive treatment for her to give her the outcome she wants. But if you look at her smile, on the left is before, on the right is after, you'll see that just by doing the aligner treatment alone, we have improved the aesthetics of it. We improved the aesthetics. We've improved the smile. The upper segment, the upper labial teeth have got a nice curve following the lower lip. We need to modify the canines slightly, soften the canines. But if you look at the buccal segments, look at the premolars, she's not showing as much gum anymore. We've managed to level the curve of Spee a little bit, so we have made some more changes which are benefiting her. It's not finished, but it's a massive improvement, but more importantly, it's been done safely and predictably. And also I feel that we've benefited her in terms of where the root position is and in respect to where the teeth are and the roots are within the bone as well. So let's now talk about implant and CBCT for planning. And again, I'm not a gambler. I'll take calculated risks, I guess, but everything is calculated and planned, and we want to reduce and mitigate our risk. And so I'm not going to, play roulette with what I'm doing, especially with implant treatment as well. We want to control it. And so in our practice, we do navigated implant placement through CBCT. Everything is planned. Everything is done in a way in which we can see, plan, and move forward in a predictable way. This is Astra implants using SciCat software. Planning the implant placement, but planning the restorative outcome as well. So we're creating things or treatments to be as simple and as precise as possible. So not only are we getting the implant in the best position within the bone, but also place the implant in the best position to restore that tooth with the best aesthetics. In this case, there's 3 teeth. This was done by my business partner. There's 2 implants on the right and 1 on the left. And again, each tooth has been planned to be in the best position, so therefore the implant is based around where the tooth wants to be. Each tooth then has a report, or each implant has a report. We can see from every angle, from every section, we know exactly where it's going, we know exactly what size implant, etc., etc. It's all planned using the CBCT. So CBCT data and information is critical for all our implant placements. We wouldn't place one without it anymore because you're just going blind. You're gambling, and we won't gamble. This is then the surgical treatment that we did. We planned everything, as you can see, on the left-hand side, and then on the right, we've produced a surgical guide, and the implants are placed using the Astra Navigation, surgical kit, placed in exactly the right position. It's like painting by numbers. Then you know where it's going. You know how predictable that's going to be, and you've nothing to worry about. We get a surgical guide report, and we move forwards on that basis with the drilling protocols and the accuracy of the stent, etc. And the implants get placed. And as you can see, the implants were placed in exactly where we want them to go. If you look at the top X-ray, you can see how we're literally just going beautifully along the side of the sinus wall, but it's been placed in a position that it can be restored nicely, where we can get into that implant with a nice straight screw. We don't have to use any angles. We just want to make it as simple as possible, both in terms of placement, maximise the implant bone interface, and also make our restorative options as simple as possible as well. And so there you go. Hopefully that's shown you that actually X-rays can be exciting, and I'm the last person to ever think that, but it's really changed how we work in our practice and how my clinical day evolves as I go through from scanning teeth to actually using a CBCT, both in terms of aligner treatment and in terms of implant care as well. So a detailed diagnosis, digital diagnosis, sorry, is key to everything for us now. Without that, we can't function and work, not predictably anyway. One thing I would say is use all the digital diagnostic tools at your disposal. Everything you can. If you've got a CBCT and you can do a low dose mode, then use it. It enhances your planning of treatment. I found that with aligners, and I wouldn't do any aligner care now without that. And it has been a game changer for me. It's totally changed everything I do. It's changed how I work, it's changed how I think, and it's changed how I communicate with the patient as well. Patients can see the care and attention we're giving their treatment. They can see what we're trying to achieve, and they appreciate that. And they then move forward with us with complete confidence that we know what we're doing. We're at the top of our game with this, and they see that, and they respond to that in a positive way. And it's shifted my acceptance, and I know other clinicians' acceptance as well, of using CBCTs. Yes, a standard and high definition CBT may be a little bit too far, but the low dose settings, there's no reason. If I'm going to take an OPT, why would I bother if I can take a low dose CBCT? It takes me a bit more time and work to assess where the roots are in the bone, but I'd much rather do that than not. In the treatment planning, digital diagnosis, detailed treatment planning and diagnosis key to successful outcomes. So I'm planning all my treatments. Again, not only am I diagnosing the issues using the CBCT meshed with a scan, I'm using it to plan my treatment. So as I get the plan back from SureSmile, I can then actively move those teeth within the bone. I know where those roots are going, and I can change the plan and adapt the plan knowing where they're going, knowing what the final outcome is likely to be. Confidence and predictability. It's the same story as we work through this. And again, use all the digital planning tools at your disposal. And again, it's been a game changer as well. The digital planning, not only the digital diagnosis, has changed how I function and how I work and how I think, and how the patients respond then to the plan in which we present to them. Again, low-dose CBCT has shifted our acceptance of CBCT for planning, and even with implants as well. Both with orthodontics and implant care, low-dose CBCTs, there's no need to take a full definition. It's allowed us to integrate and use it in cases where we wouldn't normally have done that. And treatment, orthodontics, implantology, and endodontics. The endodontic case I showed you, I treated those myself, they're my own endos, and again I can see the before and afters, I can see the outcomes I've had with the low-dose CBCT, so I don't need a high-definition CBCT for that. I can use a low dose for the patient, and I can still get the diagnostic yield that I need for that. So again, it's a game changer. I've got improved outcomes, both in terms of control, in safety for the patient, in the health of the final outcome, and then in the aesthetics. And aesthetics comes at the bottom, really, because control, safety, and health are key to this. Well, thank you very much for listening, everybody. I hope you found that useful and interesting, as I am doing now, and I hope you enjoy the rest of the conference.